So hello everyone, welcome to the Read With Me session. Today we'll be discussing a very important topic for the examination, that is hypoxic ischemic encephalopathy and transcranial ultrasound of the neonates. So neonatal encephalopathy following birth asphyxia or perinatal hypoxia is referred to as hypoxic ischemic encephalopathy. So imaging role is actually to image the pathologic lesions and predict the clinical outcome. Typically the imaging, neonate HIE is divided into premature neonate and mature neonate. Less than 36 weeks is premature neonate and more than 36 weeks is actually a mature neonate. So both the brain anatomy is actually different. Hence the findings on imaging is also different. So coming to a premature neonate, that is less than 36 weeks, it occurs because of increased chances of hypoxic insult due to a very low birth weight. And also because of hyaline membrane disease and antepartum placental abruption. So there are two categories of hypoxia that is typically seen: a severe hypoxia and mild to moderate hypoxia. In case of severe hypoxia in a preterm neonate, what actually happens is the most metabolically active regions within the brain in this period, that is the deep gray matter, the thalami, they get affected. So the typical involvement in a premature neonate is of thalami, anterior vermis and dorsal brainstem. Thalami, anterior vermis and dorsal brainstem are the most frequently affected. The basal ganglia and the perirolanic cortex myelinate around 35 to 36 weeks of gestation, and therefore they are less severely and less frequently involved in the thalami. This is just opposite to what actually happens in a term neonate. In a term neonate, in case of severe total hypoxia, there is sudden total loss of oxygenation, and because of that, basal ganglia involvement is more commonly seen than the thalamus. Now basal ganglia involvement, why? Because it is myelinated by the time the term is reached. Hence the basal ganglia involvement is more common than the thalamus, whereas in preterm thalamus, the thalamus, the anterior vermis and the dorsal brainstem involvement is more common. Then coming to the mild to moderate category. So in mild to moderate category, the most common pattern of insult in a premature neonatal brain can be of two main types. It can be a hemorrhage or it can be periventricular leukomalacia. So intracranial hemorrhage in a premature neonate is directly related to the degree of gestational immaturity, because the germinal matrix, the site of initial bleed, is a highly vascular area within the ventricular wall in the caudothalamic groove, and the germinal matrix is the most prominent and active between the 8 to 28 weeks of gestation. Germinal matrix hemorrhage typically seen in the premature infants, and it is seen associated with other predisposing factors like RDS. So when there is ischemic insult, why this hemorrhage is happening is because when there is ischemic insult to this particular baby because of RDS and other determinants of prematurity, there is reperfusion of this particular area, and the damaged cerebral autoregulation associated with sudden rapid increase in the cerebral blood flow or perfusion pressure leads to rupture of the fragile weakened blood vessels in the germinal matrix bed. So the germinal matrix involutes by 34 weeks. Hence the last portion of the germinal matrix to involute is the ganglionic eminence, which is located deep to the ependyma in the caudothalamic groove. Hence this is the area which is commonly affected. In term neonates, we don't see hemorrhage that often as compared to preterm neonates, because the germinal matrix actually involutes. In intraventricular hemorrhage, it can either be from a germinal matrix hemorrhage, that is extension into the intraventricles, or it can be from a choroid plexus bleeding in the first place. So grading of intracranial hemorrhage in a neonate is as given by the Papile grading. As grade 1 is hemorrhage is confined to the germinal matrix. In grade 2, the intraventricular hemorrhage occurs without ventricular dilatation. In grade 3, intraventricular hemorrhage is there associated with ventricular dilatation, and in grade 4, the bleeding into the brain parenchyma occurs, which is called periventricular hemorrhagic infarction. So PVHI, that is periventricular hemorrhagic infarction, unlike a normal hemorrhage, it occurs in the area of ischemia. That is, periventricular hemorrhagic infarction occurs more anteriorly and roughly is triangular in shape, with the apex of the triangular in the midline. The germinal matrix hemorrhage and intraventricular hemorrhage causes a compromise of the terminal veins underlying the germinal matrix. Because of that, congestion, thrombosis and rupture of the medullary veins draining the deep white matter occurs, because of which there is hemorrhagic venous infarcts in the periventricular parenchyma. And hence PVHI, that is periventricular hemorrhagic infarction, eventually progresses to liquefactive brain necrosis and porencephalic cyst formation. Imaging in intracranial hemorrhage is by sonography is done by the transfontanel route, and optimum time for sonographic detection of intracranial hemorrhage is 4th to 7th day. To monitor the development of hydrocephalus as a complication of IVH, ultrasound is recommended on 14th day, and if negative, then on 3rd month. Limitation of ultrasound is that it cannot detect SAH and hemorrhage in the posterior fossa and the parieto-occipital region very well. Coming to another entity of the mild to moderate hypoxia is PVL. So unlike intracerebral hemorrhage, where prematurity is a clear risk factor for development of PVL, a large number of ante and perinatal events have been identified, which may result in a hypoperfusion to the fetal cerebral tissue or injury to the oligodendroglial cells. So besides the hypoxic ischemic insult, other causes like infection, metabolic diseases and hydrocephalus can also cause similar changes in the white matter, periventricular leukomalacia. So in a premature neonatal brain, the periventricular area is almost totally perfused by the penetrating arteries that extend inward from the surface of the brain, that is the ventriculopital flow. So the junction of the ventriculopital and the fugal vessels is the watershed area, which exists in the periventricular region in a premature neonate. So in an event of hypoxic ischemic insult, this periventricular watershed area is at highest risk. So this combined with the relative hypovascularity of the periventricular white matter plays an important role in the development of PVL. And again, another important factor is that in periventricular region, typically the cells that are present are pro-oligodendrocytes, and pro-oligodendrocytes are more susceptible to hypoxic ischemia than oligodendrocytes. And what actually happens pathologically is there is coagulation necrosis first, and then there is cavitation evolving over the next 2 to 4 weeks, and then after several weeks the cysts collapse and disappear completely with residual white matter, atrophy and ventriculomegaly. In imaging of PVL on ultrasound, PVL is suspected on ultrasound studies when there is increase in echogenicity present in the periventricular region on ultrasound, and periventricular areas with increased echogenicity is visible 24 to 48 hours of ischemic insult. However, there are two major pitfalls to this. In normal newborns also there is periventricular increased echogenicity, which is called periventricular blush. So blush is normal, and brain edema also appears bright on ultrasound. So there are two important pitfalls. Therefore, presence of increased echogenicity itself does not diagnose PVL. A reliable sign of PVL is the presence of periventricular flare. A flare is actually the brightness of echogenicity due to flare is more than that of normal periventricular echogenicity, and it approaches equal to that of the adjacent choroid plexus. The grades of PVL include grade 1 is periventricular echogenic area persistent for more than a week. Grade 2 is periventricular echogenic area evolving into localized small frontoparietal cysts. In 3, there is periventricular echogenic area evolving into multiple cysts in the parieto-occipital white matter. And in 4, the echogenic area in the deep white matter evolving into multiple subcortical cysts called multicystic encephalopathy. So how a term brain is actually different from preterm brain in case of this insult is, with maturity of the infant, 3 important anatomical changes occur. There is involution and regression of the germinal matrix. Hence, there is decreased incidence of intracranial hemorrhage. Then the site susceptible for hypoxic ischemic changes, that is a watershed zone, it shifts from the periventricular region to the more peripheral location in the subcortical region. Then, while earlier the response of the preterm brain to trauma trauma was actually liquefaction and resorption of the damaged brain, the mature brain responds by a reactive astrogliosis. So, they are the differences between the insults in a preterm and a term neonate. Coming to the transcranial neonatal ultrasound limitations, limitations of this ultrasound are that typically ultrasound sign of ischemia in a full term is absent in the first 24 hours. And it's difficult to detect migrational disorders like cortical dysplasias and all. Then the scanning sites include anterior fontanelle, which is the most common site that is used, midline posterior fontanelle, squamotemporal view, posterolateral or mastoid fontanelle, and foramen magnum. In the normal variants in anatomy include immature sulcation in the premature infants, megacisterna magna, asymmetric ventricular size, choroid plexus variants like cystic lesion or echogenic variant, and periventricular halo and septum pellucidum, which may be confused to a cystic lesion. The grading of PVL is actually called De Vries grading.